Today, we are taking a deep dive into one of the most urgent and just high-stakes diagnoses in all of medicine, the heart attack. Despite these massive medical advances we've seen over the last few decades, acute myocardial infarction, or AMI, it remains a staggering public health challenge.
It absolutely does.
Yeah.
And when you look at the numbers, I mean, the scale of the problem is just so clear.
Yeah.
Our sources show that in the United States alone, something like 605,000 people experience a new AMI every single year.
A new one? That's not even counting recurrent.
Exactly. And on top of that, you have hundreds of thousands more suffering a recurrence. But the statistic that truly underlines the urgency is this one. About half of all AMI-related deaths happen before the patient ever reaches a hospital.
That statistic, the half that happened before arrival, is just terrifying.
It is.
It immediately tells you that understanding the anatomy of this crisis, from the very first symptom to the final diagnosis, is just essential knowledge. And for this dive, we're really focusing on the most critical, the most immediate form of heart attack, the STEMI.
That's our mission today. For the patient who does present with that ST segment elevation, the urgency is absolute, and the management pathway is completely different. It demands immediate intervention. So this deep dive is built on a really comprehensive analysis of that exact pathophysiology and the critical management algorithms that guide the treatment of STEMI.
Okay, so let's start at the very first point of contact, the patient's initial complaint. When we talk to the public, the typical description is often, crushing chest pain. But the clinical literature suggests this ischemic discomfort is far more complex and often pretty misleading.
It's rarely a single, sharp, or stabbing sensation. The primary complaint, that ischemic discomfort, is typically deep. It's visceral.
Visceral?
Yeah, and patients often struggle to articulate it. They'll resort to descriptions like heavy, squeezing, or, that classic crushing sensation you mentioned. And the location is central, involving the mid-chest, but it also critically and frequently involves the epigastrium.
The upper abdomen.
Exactly, the upper middle abdomen, just below the sternum.
And that lower location right beneath the xiphoid process, that's where the trouble begins in terms of misdiagnosis, isn't it?
Precisely. The frequent location of the pain in the epigastrium leads to the extremely common and often fatal mistaken impression of indigestion.
Right. I just ate a bad burrito.
That's what you hear. Patients will argue that they just ate something too rich, and that leads to these dangerous delays. Now, the pain often radiates to the arms, particularly the left, but we also see radiation to the back, the lower jaw, and the neck. But there's an important boundary here.
Okay.
An important geographical boundary for this pain, which can be useful in triage, is that it never radiates below the umbilicus.
That's a great clinical pearl. Now, in the chaotic environment of the emergency department, where minutes matter, the team has to rapidly rule out other equally serious, life-threatening conditions. What are the key differentials that can mimic STEMI pain?
Well, the differential diagnosis includes things like acute pericarditis, a pulmonary embolism, acute aortic dissection, and even serious GI issues like an esophageal rupture.
All life-threatening.
All of them. But when you're sorting these out, our sources point to a critical, almost surgical detail regarding pericarditis.
What's that?
Radiation of discomfort to the trapezius muscle is not seen in STEMI. So if the patient points to their shoulder or their neck muscles and says the pain goes there, it strongly suggests pericarditis, which changes the entire management path away from immediate reperfusion.
Wow. That's a perfect example of a high-leverage piece of information, one small piece of data that redirects a massive clinical effort. Now let's talk about the patients who don't present with that crushing feeling at all, the so-called silent MIs.
Yes, we absolutely must emphasize that chest pain is not a universal constant. The phenomenon of painless STEMIs, or atypical presentations, is far more common in two distinct populations. Patients with diabetes mellitus.
Due to neuropathy.
Often due to autonomic neuropathy, exactly. And the elderly. And if you are not actively looking for it, you will miss it entirely.
So how does the presentation shift in these vulnerable patients? What are we looking for?
The symptoms become vague and nonspecific. Instead of pain, the patient might just report a sudden profound breathlessness, new onset dyspnea or syncope, which is loss of consciousness.
Wow.
And most worryingly, in the elderly, it can present as just a simple confusional state, profound unexplained weakness, or sudden unexplained low blood pressure. These are the pagerless STEMIs.
The ones that slip through the cracks.
They're the ones that easily get misdiagnosed as, routine geriatric decline or just a bad day, delaying that life-saving ECG and reperfusion therapy.
It sounds like the combination of these non-specific symptoms and the body's own, hyperreaction is the defining chaos of that first hour.
It is. We look for physical signs to help confirm our suspicion. Patients with an anterior infarction, where the damage is significant, often show signs of sympathetic hyperactivity, a racing heart, tachycardia, and elevated blood pressure.
The fight-or-flight response.
Exactly. Conversely, those with an inferior infarction, often involving the right coronary artery, might show parasympathetic hyperactivity, so a slow heart rate, bradycardia, and hypotension. But the most reliable pairing, the one that strongly suggests an acute occlusion, is substernal chest pain that persists for more than 30 minutes, coupled with diaphoresis or heavy sweating.
And this brings us to the pivotal moment in triage, the 12-lead ECG. This is where the patient is instantly routed onto one of two radically different management tracks.
The ECG is the center of the universe for acute triage. Right. If a patient presents with ischemic discomfort at rest, the working diagnosis is always acute coronary syndrome, or ACS.
Right.
The ECG immediately separates those with clear ST segment elevation, that's the STEMI cohort, requiring immediate intervention, from those without ST elevation who are categorized as NST-ACS.
Our source material lays out a crucial diagnostic flowchart here, branching from ischemic discomfort into the underlying mechanisms. Can we trace that pathway?
Certainly. The entire spectrum really breaks down into two fundamental mechanisms. The first is what we call non-thrombotic supply-demand imbalance.
Okay, so this is a type 2 myocardial infarction.
Exactly. It's not caused by a major acute rupture and clotting. Instead, it includes things like demand-related unstable angina and type 2 STEMI, which you confirm with positive cardiac biomarkers.
So the heart's oxygen demand just outstrips a limited supply.
Right, often due to conditions like severe sepsis, hemorrhage, or profound anemia, acting on a vessel that already has some fixed atherosclerosis. The underlying blockage is stable, but the systemic stress is overwhelming it.
And the second pathway is the true emergency, the atherothrombotic acute coronary syndrome.
This is the crisis scenario. It's thrombotic-mediated and includes type 1 STEMI, type 1 STEMI, and thrombotic-mediated unstable angina. Here, the culprit is plaque instability.
Plaque rupture.
Plaque rupture, followed by thrombus formation, though sometimes it can be vasospasm or endothelial dysfunction. The distinction between NSTEMI and STEMI is purely about the degree of occlusion and what the ECG shows. If the clot causes a total acute shutdown, we see that ST segment elevation, designating a type 1 STEMI.
But if it's not a total shutdown?
If the clot is large but subtotal, allowing for some trickle of blood flow, the ECG is normal, or might show only T-wave or ST segment depression, and that leads to an STEMI or a UA diagnosis.
That makes the distinction based on flow, not location. And this ties into the historical change in how we classify these things.
That's right. The modern classification, STEM and STEMI, it replaced the older terms like transmural versus non-transmural or Q-wave versus non-Q-wave MIs.
And why was that change so important?
It was a necessary evolution because advanced imaging, particularly cardiac MRI, showed us that the presence of a Q-wave on the ECG isn't just about the injury crossing the entire wall thickness transmurality. It's actually more dependent on the total volume of infarcted tissue. So the STEM and STEMI classification is superior because it directly informs the time-sensitive treatment path. STEMI means go to the cath lab now, and STEMI means stabilize first.
Okay, so having established the clinical presentation, let's go deeper into the source of the problem, the coronary artery itself. We mentioned that slow, high-grade blockages usually don't cause these sudden events. Why is the rupture of a moderate plaque so much more dangerous than a 90% stenosis?
It's a crucial distinction, and it's a bit counterintuitive. STEMI almost always results from an abrupt thrombotic occlusion of an artery.
An abrupt event?
Yes. Chronic, severe blockages, say 90% stenosis, paradoxically allow the heart time to develop extensive collateral circulation.
Natural bypasses.
Essentially, yes.
Yeah.
Natural bypass pathways that route blood around the blockage. So when a severe, stable blockage is present, the heart is actually protected. But when a moderate, previously harmless-looking plaque ruptures, the blockage is acute, and those collateral pathways haven't had time to form, leading to immediate large-scale tissue death.
So it's not about the size of the blockage, it's about the stability of the vessel wall. What are the specific characteristics of these vulnerable plaques that make them so prone to collapse?
The unstable plaque structure is chemically and physically distinct. Rupture-prone plaques have several defining characteristics. They contain a large, rich lipid core, which is highly thrombogenic,
A trigger for clotting.
a huge trigger. They're also covered by a very thin fibrous cap, which is structurally weak. They often undergo what's called expansive remodeling, meaning the artery wall swells outward, which can actually mask the severity of the blockage on an angiogram. And they exhibit neovascularization, the growth of fragile new microvessels within the plaque itself.
I found the note on inflammation fascinating. It seems like inflammation is the accelerant here, weakening that cap.
Absolutely. We see adventitial inflammation and plaque hemorrhage. The presence of macrophages within the cap indicates ongoing inflammation, and they secrete enzymes that degrade the collagen and thin that protective fibrous cap.
It just eats it away.
It eats it away. Combine this with a spotty calcification pattern, and you have a structure that is just guaranteed to fail under stress, exposing all of its contents to the blood.
And once that rupture occurs, exposing the highly reactive lipids and collagen, the body initiates a cascade that guarantees total occlusion. Can you describe that rapid, almost instantaneous sequence of thrombus formation?
The sequence is breathtakingly fast. Step 1. The immediate formation of a platelet monolayer at the site of the disruption, trying to patch the leak.
The first responder.
Right. Step 2. The exposure to agonists. The site exposes collagen, ADP, epinephrine, serotonin, all of which instantly activate those resting platelets.
And then step 3 is the feedback loop.
Yes. Activated platelets release thromboxane A2. This chemical is a double whammy. It's a potent local vasoconstrictor, so it tightens the artery further and physically traps the growing clot, and it dramatically increases platelet activation, potentially making the resulting clot resistant to any kind of lysis.
So the body's own hemostatic response, designed to save you from bleeding out, becomes the engine of total circulatory collapse.
Precisely. Step 4 is aggregation. Platelet activation causes a critical change in the glycoprotein IBA receptor. This activated receptor then binds fibrinogen.
And fibrinogen is like the glue?
It's the molecular bridge. It's multivalent, so it can bind to 2 different platelets at once, cross-linking them into this massive, tightly packed aggregate. And at the same time, the exposed tissue factor on the plaque surface activates the entire coagulation cascade, leading to a burst of thrombin.
And thrombin makes fibrin.
Thrombin rapidly converts soluble fibrinogen into insoluble fibrin strands. The final fatal result is the total occlusion of the artery by a reinforced thrombus, a mesh of platelet aggregates bound together by dense fibrin.
A complete shutdown. Once that flow is blocked, we move into damage control. The infarct size, how much heart muscle dies, is critical for the patient's long-term outcome. What are the key factors determining that final size?
Our sources identify 7 key determinants, and it paints a picture of real complexity. Beyond the obvious, like the size of the territory the affected vessel supplied, we have the critical variables of time and collateral supply.
Right.
The duration of occlusion is perhaps the single most important factor. Then, the quantity of collateral blood supply, how many of those natural bypasses the patient had developed, can dramatically limit the damage.
What about the metabolic and physical determinants?
We have to consider the oxygen demand of the affected myocardium. A heart racing at 120 beats per minute will die faster than one resting at 60. Then there are endogenous factors that can promote spontaneous thrombus lysis, which can happen, though it's pretty rare.
And the final one is the no reflow phenomenon.
Yes, the adequacy of myocardial perfusion when flow is restored. This is a huge problem in treatment.
This complexity is beautifully synthesized in the material by the concept of the vulnerability triad.
That triad is a great way to think about it. It shows that the infarct size is truly systemic, not just local. You have the vulnerable plaque itself, its inflammation, location, the size of the lipid core.
Okay.
Then you have thrombogenic blood systemic inflammation, comorbidities like diabetes, genetics.
So the patient's baseline state.
Exactly. And finally, the vulnerable myocardium itself, the duration of ischemia, and the individual susceptibility of the heart muscle. The interaction of all 3 dictates whether the patient suffers a small, salvageable infarct or a massive, debilitating one.
Focusing on that final determinant, the no reflow state. If the cardiologist successfully opens the main artery with a stent, why does the tissue still die?
The problem shifts from the major epicardial vessel, the highway, to the downstream microcirculation, the side street.
I see.
No reflow means that even though the main highway is open, the smaller capillaries and arterioles are blocked or dysfunctional. And this microvascular damage is catastrophic and multifactorial.
What causes it?
You have endothelial dysfunction from the prolonged ischemia. You have trapped leukocytes and platelets interacting in the tiny vessels. You have thrombus debris and microemboli that break off the main clot and lodge downstream. And finally, you have tissue swelling edema, which physically compresses the small vessels from the outside.
So even with an open artery, there's no perfusion.
Exactly. The resulting lack of perfusion severely limits the salvage of heart tissue, even after a seemingly successful PCI.
We've established the acute mechanism. Time is now running, and the tissue is dying. But after the damage is done, the heart begins this complex inflammatory and repair process. What is the timeline of this healing, and how does the body manage the literal debris field inside the ventricle?
The healing phase is highly orchestrated. A STEMI progresses through the acute phase, which is the first few hours to about 7 days.
Okay.
The healing phase from day 7 to 28, and then the healed stage, which is anything 29 days and beyond. And immediately following the injury, the myocardium initiates this aggressive cellular cleanup and reconstruction.
Walk us through that coordinated cellular response. Who are the primary actors in that initial cleanup?
The initial phase is dominated by damage clearance, and it's highly pro-inflammatory. Polymorphonuclear leukocytes, the earliest responders, are recruited very quickly for phagocytosis.
So they're eating the dead cells.
They're literally engulfing and removing dead cells and debris, and at the same time, they're secreting enzymes to degrade the matrix and prepare the tissue for repair. Alongside them, you have pro-inflammatory monocytes, often identified by the CCR2+ receptor, which aid in this early destructive cleanup phase.
And when does the shift from destruction to construction occur?
That's the critical pivot. The later phase, which really drives the long-term outcome, is dominated by reparative monocytes. These cells are phenomenal. They shift the immune landscape, and they stimulate monocyte-derived fibroblasts. These fibroblasts are the construction crew. They're responsible for producing the extracellular matrix and synthesizing interstitial collagen. This whole process, resolving inflammation, promoting new blood vessel growth, and creating a strong, dense collagen scar, is essential.
And why is that scar formation so vital?
Because a poor scar leads to the mechanical failures we'll discuss later. A robust, non-expansive scar is the body's way of preventing the left ventricle from undergoing adverse changes, specifically that expansive ventricular remodeling.
The pathological dilation and thinning.
Exactly, which inevitably precedes chronic heart failure. The scar essentially holds the wall together under pressure. And the source material also points to this emerging concept of emergency hematopoiesis, where the body actively mobilizes specialized leukocyte progenitor cells from the bone marrow to accelerate this healing. It just shows how systemically stressed the body is.
Moving from the cellular debris field to the clinical diagnostic marker, troponin. How can we detect something that happened deep inside the heart muscle cells via a simple blood test?
It's a mechanism of sheer volume overload. As heart muscle cells undergo necrosis, the proteins inside them, particularly troponin, are released into the local tissue.
The interstitium.
Into the interstitium, right? They only become detectable in the peripheral blood when the capacity of the cardiac lymphatics, which are like the heart's sewer system, is overwhelmed. The debris then spills over into the venous circulation, and that's when it becomes measurable.
And troponin is now the undisputed gold standard for confirming necrosis.
Absolutely. We use cardiac-specific troponin T, or CTNT, and troponin I, CTNI. The formal criterion for diagnosing an acute MI is a definite rise and/or fall in those CTN values, with at least one value spiking past that critical 99th percentile upper reference limit.
And how high can they go?
In a large STEMA, these levels can climb 20 to 50 times the upper limit, and crucially, they remain elevated for 7 to 10 days, which gives you a long diagnostic window.
We noted earlier, though, that troponin is less useful for the immediate STEMI triage than the ECG. Why is that if it's the definitive test for injury?
It's all about time. The damage takes time to measure. Even with highly sensitive troponin assays, it still takes a few hours for the levels to exceed the detection threshold and definitely show that rise and fall pattern.
And you don't have hours.
You don't have hours. The decision to perform urgent reperfusion primary PCI cannot wait for lab results. The ECG identifies the total occlusion immediately, which is the immediate threat to life. Troponin, measured later, confirms the diagnosis, helps quantify the injury, and distinguishes a type 1 from a type 2 MI.
That role of quantifying injury often fell to CK-MB in the past. Where does creatine kinase MB isoform fit in now?
CK-MB is supplementary today because it just lacks the cardiac specificity of troponin. However, it does retain one important clinical utility: detecting early reinfarction.
Oh, interesting.
Yeah, since troponin stays elevated for 7 to 10 days, a second, smaller infarct during that time would just look like a bump on an already high plateau. You wouldn't be able to tell.
Right.
But CK-MB declines more rapidly. So if a patient has renewed chest pain 48 hours post-STEMI, a new rise in CKMB is a much better, quicker indicator of a fresh, acute reocclusion.
And the size of the injury relates to the protein release?
Yes. The total quantity of protein released correlates strongly with the infarct size, and if the artery is successfully recanalized, either by intervention or spontaneously, the peak concentration of biomarkers will happen earlier and faster.
The washout phenomena.
Exactly, the washout phenomena. The sudden restoration of flow quickly flushes all those accumulated proteins into the bloodstream.
Let's briefly cover imaging. When does echocardiography become indispensable in the acute phase?
Echocardiography is crucial for prognostic assessment, not necessarily for the initial diagnosis in a clear STEMI. Abnormalities of wall motion are virtually universal in the affected area.
So it's more for when the ECG is ambiguous.
Yes. Its primary value in acute triage is as a rapid screening tool when the ECG is non-diagnostic. It can reveal regional wall motion abnormalities that just scream, ischemia is happening now, helping the team decide on urgent reperfusion if the ECG is silent. But its long-term importance is assessing left ventricular function, the ejection fraction, and identifying those critical mechanical complications.
And nuclear imaging.
Radionuclide imaging is available, but it's rarely used for acute STEMI. It shows a defect, a cold spot, in the infarct zone. But the limitation is significant. It can't reliably distinguish between an acute injury and an old chronic scar, which makes it non-specific for the immediate crisis.
To bring all these clinical and lab findings together, let's quickly solidify the formal definitions of MI types as outlined in the modern guidelines.
Right. The universal definition of MI is necessary because it standardizes how we classify these events. All acute MI, that's types 1, 2, and 3, requires two components: acute myocardial injury,
The troponin rise and fall.
the troponin rise and fall, plus clinical evidence of ischemia. That clinical evidence can be symptoms, ECG changes, new Q waves, a new wall motion abnormality, or actually identifying a coronary thrombus.
And the types clarify the cause, which dictates future prevention.
Exactly. Type 1 MI is the classic event acute atherothrombosis from plaque rupture. Type 2 MI is the secondary non-atherothrombotic event caused by a major supply-demand imbalance.
Like blood loss or a tachyarrhythmia.
Right. The vessel itself didn't rupture, the systemic stress killed the tissue. And type 3 MI is the definition for a patient who dies suddenly from suspected cardiac ischemia before biomarker results are even available.
And then we have the specific procedure-related types.
Yes, type 4 and type 5 MIs are procedure-related. Type 4A MI is after a PCI, and type 5 MI is after a CAG, a bypass graft. These require specific, very high troponin thresholds for diagnosis, 5 times the upper limit for type 4A, and 10 times for type 5, along with new evidence of ischemia. This helps us distinguish minor, expected injury during a procedure from a genuine, clinically significant MI.
We noted at the outset that half of all AMI deaths happen before the hospital. This emphasizes the need for an integrated, synchronized system, the chain of survival. Where is the single greatest point of failure in that chain?
The single biggest delay is almost always patient-dependent. The time between when symptoms start and when the patient actually calls for help.
The decision to call.
That decision. Public education, ensuring patients at risk understand the atypical symptoms, the profound weakness or breathlessness, that is the ultimate first step. The risk of sudden ventricular fibrillation is highest in the very first hour, so that time frame is truly lethal.
Once that call is made, how rapidly and sophisticatedly must EMS respond?
EMS deployment has to be rapid and capable of advanced cardiac life support, and crucially, that includes defibrillation. In remote regions, far from a PCI-capable center, the role of EMS is even more expanded.
How so?
Trained personnel must be able to acquire and transmit 12 lit ECGs to a medical command center for a rapid diagnosis. And if it's confirmed as a STEMI and the transport time is going to be too long, EMS is authorized to initiate fibrinolytic therapy right there in the field.
Once the patient is stabilized and arriving at the emergency department, the focus becomes hyper-accelerated logistics.
The overarching goal in the ED is minimizing the time from first medical contact FMC to the initiation of reperfusion therapy. For every 30-minute delay in reperfusion, mortality goes up.
So the ED goals are crisp.
Very. Confirm the diagnosis, control discomfort, and route the patient to the cath lab or to the needle as fast as humanly possible.
You for the decisive reperfusion strategy. Let's detail the immediate pharmacological interventions for stabilization and pain control. We have to start with the single most effective drug in the acute phase, aspirin.
Aspirin is non-negotiable across the entire spectrum of ACS. The goal is rapid, irreversible inhibition of cyclooxygenase 1, which shuts down the production of that platelet-activating thromboxane A2.
And the critical detail here is how you give it.
Yes. The initial dose of 160-325 milligrams must be chewed for rapid buccal absorption. You need it in the system as quickly as possible.
What about oxygen? Why is it no longer standard practice to put everyone on 100% O2?
Well, clinical evidence has guided this change. Supplemental oxygen is now only given if the patient shows evidence of hypoxemia, so an O2 saturation less than 90%.
Even if they're not hypoxemic.
Giving supplemental oxygen to a normoxemic patient is not only unhelpful, but studies suggest it might lead to mild coronary vasoconstriction, which could potentially increase the infarct size.
Next, nitroglycerin, the classic chest pain reliever.
Right. Nitroglycerin is used for persistent ischemic symptoms. Its benefit is twofold. It decreases myocardial O2 demand by lowering preload, and it can potentially increase supply by dilating vessels. But its use is heavily restricted.
What are the big contraindications?
We have to avoid it if the systolic blood pressure is low, so less than 90, if there's any suspicion of a right ventricular infarction, or if the patient has taken a phosphodiesterase 5 inhibitor in the last 24 hours. That combination can cause catastrophic, irreversible hypotension.
And for refractory pain, we use morphine. Given its efficacy, what are the necessary cautions?
Morphine is highly effective given IV and titrated doses. It relieves pain and anxiety, which is great, but it can cause hypotension and a reduction in cardiac output due to venous pooling.
I also recall a concern that morphine might interfere with the absorption of the antiplatelet drugs the patient desperately needs.
That concern is valid. Morphine can slow gastric motility, potentially delaying the absorption of oral antiplatelets. However, despite this pharmacokinetic concern, current clinical data have not demonstrated an increase in adverse clinical outcomes, so its use for severe pain relief remains standard practice.
Finally, before the cath lab, the acute use of beta blockers.
Acute intravenous beta blockers, like metoprolol, are incredibly valuable. They control pain by diminishing oxygen demand, and crucially, they reduce the risk of reinfarction and life-threatening ventricular fibrillation. But this has to be strictly weighed against potential harm.
What are the absolute red flags for acute IV beta blocker administration?
They are absolutely contraindicated if the patient has a heart rate below 60, a systolic pressure below 100, a prolonged PR interval on the ECG, or any clinical signs of acute heart failure. If those are present, the risk just outweighs the benefit.
Okay, we stabilized the patient and confirmed the diagnosis with the ECG. We now face the critical decision: primary PCI or fibrinolysis. This is the high-stakes algorithm.
This decision pathway is governed entirely by time and logistics. Reperfusion is indicated if the ST segment elevation meets strict criteria. The choice depends on where the patient is. Primary PCI percutaneous coronary intervention, usually stenting, is the preferred gold standard strategy.
If it can be delivered quickly.
If it can be delivered quickly by an experienced team, that's the key.
What are the absolute time metrics we are trying to hit for primary PCI?
At a PCI-capable hospital, the target time from first medical contact to the moment the device crosses the lesion, the FMC to device time, must be less than or equal to 90 minutes.
And if they're coming from another hospital?
If the patient is being transferred, that window extends to 120 minutes. If the anticipated transfer time exceeds 120 minutes, fibrinolysis becomes the superior choice.
Why is PCI preferred even if fibrinolysis might be faster in some cases?
Because PCI is generally more definitive. It's more effective at achieving complete and lasting revascularization, which translates into better outcomes, including a reduced risk of reinfarction and hemorrhagic complications compared to clot-busting drugs.
There's a major nuance in the PCI protocol regarding multivessel disease that we must clarify, especially concerning shock.
This is a modern life-saving distinction. In stable patients, not in shock, studies now support performing PCI on non-culprit vessels, those other blockages, either immediately or within 45 days. This strategy significantly lowers the rate of future cardiovascular events.
But the rule flips in cardiogenic shock.
The rule completely flips. For those patients, routine immediate PCI of non-culprit arteries is contraindicated. Focusing only on the culprit lesion is mandatory because extending the procedure in a critically ill patient increases the risk of death and severe renal failure.
So if the time to PCI exceeds 120 minutes, we are forced to use fibrinolysis. What is the timeline for these drugs?
Fibrinolysis is the backup strategy if timely PCI is unavailable. The target is a lightning-fast door-to-needle time of less than or equal to 30 minutes. The agents work by converting plasminogen to plasmin, dissolving that fibrin mesh.
And we measure the success of this treatment using the TMI grading system. What are we aiming for?
We use the 2MI grading system to assess flow, Grade 0 is total occlusion. Our absolute goal is TI grade 3 flow, which signifies complete to normal perfusion. Achieving grade 3 flow is directly correlated with limiting infarct size and improving mortality.
Given that we are injecting powerful clot-busting drugs, what are the absolute non-negotiable contraindications for fibrinolysis?
The primary risk is intracranial hemorrhage. So absolute contraindications include any history of hemorrhagic stroke, a non-hemorrhagic stroke within the past year, MARC, uncontrolled hypertension, suspicion of aortic dissection, or any active internal bleeding.
And what's the risk profile of that hemorrhagic stroke complication?
The incidence is low, roughly 0.5 to 0.9% of all patients treated. However, this risk is significantly age-dependent. It roughly doubles in patients over 70.
If fibrinolysis is successful at a non-PCI hospital, the patient's care isn't over. How do we integrate the pharmacologic approach with the mechanical one?
The integrated strategy dictates that all successfully licensed patients must be immediately transferred to a PCI-capable center. The goal is to perform diagnostic angiography and potential PCI within 3 to 24 hours after the drug was given.
A staged procedure.
Exactly. If, however, reperfusion fails, meaning persistent pain or ST elevation more than 90 minutes after the drug, or if reocclusion occurs, then urgent angiography, known as rescue PCI, is required immediately.
The acute crisis is over, the artery is open, the patient enters the hospital phase. This is where we shift from immediate survival to long-term prevention. What is the ideal environment for the high-risk STEMI survivor?
The first environment is the Cardiac Intensive Care Unit, the CICU. Any STEMI patient with hemodynamic or electrical instability has to be there. These units provide continuous rhythm monitoring, allowing for immediate defibrillation and rapid response.
And how quickly do we mobilize these patients? Is it still strict bed rest for days?
Not at all. While bed rest is necessary for the first 6 to 12 hours, patients without complications are actively encouraged to get up and sit in a chair within 24 hours.
That must be a huge psychological benefit.
It's huge psychologically, and it's also physically advantageous, as sitting often reduces pulmonary capillary wedge pressure. If stable, patients can typically expect discharge within 3 to 5 days.
And the diet is focused on risk reduction right from the start.
Absolutely. Initially, it's clear liquids for the first 4 to 12 hours due to aspiration risk. But the long-term prescription is strict secondary prevention. Low in fat and cholesterol, high in complex carbs, potassium, magnesium, and fiber.
Now, for the pharmacological regimen, beginning with the backbone of secondary prevention, antithrombotic therapy, we need dual antiplatelet therapy or DAPT.
Correct. The goal is to maintain the patency of that artery, especially if a stent was placed. After the initial aspirin, we add a P2Y12 inhibitor. Clopidogrel is the foundational one. It significantly reduces death, reinfarction, and stroke.
But the sources also highlight the newer third-generation inhibitors. Why switch to them if they carry a higher bleeding risk?
This is a classic risk-benefit trade-off. The third-generation inhibitors, prasugrel and ticagrelor, are significantly more potent and generally more effective at preventing subsequent ischemic events, like stent thrombosis.
But at a cost.
But at the cost of an increased risk of bleeding. So the choice really depends on the patient's bleeding history versus their ischemic risk profile. If they have a high risk of another clot, the risk of bleeding is often accepted.
Beyond DAPT, what is the role of anticoagulation during the hospital stay?
Anticoagulation is crucial to stabilize the acute phase. Unfractionated heparin, or UFH, is the standard during primary PCI. It requires meticulous management with dosing adjusted frequently to maintain a therapeutic level.
And what are the alternatives to UFH?
Low molecular weight heparins, like enoxaparin, are superior to UFH in reducing composite endpoints in fibrinolysis patients, even though they have slightly higher bleeding rates. Bivalirudin is another alternative preferred in primary PCI patients, as it's associated with a lower overall rate of bleeding.
And when is long-term oral anticoagulation necessary on top of all this?
Oral anticoagulants are necessary for at least 3 months in patients at high risk of thromboembolism. This includes patients with a large anterior infarct, severe LV dysfunction, or an echocardiogram that shows a mural thrombus, a clot lining the wall of the damaged ventricle.
We transition now to the most important long-term therapeutic goal, modulating ventricular remodeling. This is where the subtle biological battle takes place over months and years.
This is the determinant of chronic heart failure. After a large STEMI, the left ventricle undergoes significant pathological change. It changes shape, size, and thickness. It's a process of dilation and thinning that inevitably leads to chronic heart failure if it's left unchecked.
How do ACE inhibitors actively fight this remodeling? They are universally recommended for survivors.
ACE inhibitors are absolutely central. Their mechanism is twofold. They reduce systemic afterload, easing the heart's workload, and critically, they interfere with the renin-angiotensin-aldosterone system, or RAAS.
Which is highly activated post-MI.
Highly activated, and it drives fibrosis and inappropriate growth in the heart muscle. By blocking RAAS, ACE inhibitors reduce ventricular wall stress, mitigating that progressive dilation and thinning. They reduce mortality and lower the risk of recurrent MI.
Who benefits most, and for how long are they prescribed?
The maximum benefit is in high-risk patients. Anterior MI, prior MI, or depressed LV function. But a short-term benefit exists for most stable patients. Indefinite use is recommended for any patient with heart failure, reduced LV function, or hypertension. And for patients who can't tolerate the cough, ARBs are the alternative.
And we escalate therapy with mineralocorticoid receptor inhibition, or MRAs?
Yes, drugs like spironolactone or eplerenone. These are aggressive, highly targeted therapies prescribed only for patients already on ACE inhibitors who still have significant LV dysfunction and symptomatic heart failure or diabetes. The key restrictions are safety. They can't be given to patients with renal dysfunction or hyperkalemia.
Finally, we revisit beta blockers for chronic oral use.
Oral beta blockers provide long-term benefits for secondary prevention. They reduce the risk of recurrent MI and fatal ventricular arrhythmias. They should be initiated within 24 hours for stable patients and continued indefinitely unless contraindications emerge. Post-infarction risk stratification is everything, and we're looking for 4 major red flags. The biggest one, by far, is depressed left ventricular function.
Okay, let's pause there. You're talking about the LVEF, the ejection fraction. Why is an LVEF under 40% such a critical turning point?
Because the LVEF is the direct measurement of how much muscle was damaged. It tells you how well the heart is pumping. If it's under 40%, the heart is already struggling, and it's much more likely to remodel badly and develop dangerous electrical problems.
So how do you get that number so fast?
It's mandatory for every STEMI patient. The main tool is an echocardiogram, an ultrasound of the heart, sometimes cardiac MRI. But what's so fascinating is that one number, that LVEF, immediately dictates the entire long-term medication strategy. It's the branch point.
So beyond the LVEF, what are the other big danger signs?
We look for hemodynamic instability, things like fluid in the lungs, low blood pressure. Then there's persistent ischemia, which means the heart muscle still isn't getting enough blood.
They're still having chest pain.
Sometimes, or even silent ischemia, which is just EKG changes without any symptoms. And the last one is arrhythmic risk new, serious heart rhythm problems. Any of those flags means a longer stay and more intense investigation.
That brings us to the plumbing. If they've fixed the main blockage, how do you know if there aren't others just waiting to cause the next problem?
Well, it really depends on how they were treated in the first place. If they had a PCI, a stent, the doctors often fix other major blockages during that same procedure. So in that case, you might not need more testing before discharge.
But what if they just got the clot-busting drugs, the fibrinolytics?
Then stress testing is absolutely key. Before they go home, they'll do a submaximal exercise stress test. It's a low-level test, but it helps us spot any remaining ischemia, and, importantly, it helps us write an exercise prescription for them.
And if that test shows something,
Any red flags, like angina at a low workload or dangerous rhythms, that means they're heading for a cardiac cath to find and fix whatever's left.
So finally, let's talk about getting back to life. What's the timeline for recovery look like once they get home?
It's a staged, gradual process. The first week or 2 is about gentle activity, mostly walking. Normal sexual activity can usually be resumed then, too.
And returning to work.
After about 2 weeks, the doctor will clear them for more activity based on their exercise tolerance. Most people are back to work within 2 to 4 weeks.
That seems incredibly fast. But it sounds like it depends on the patient really engaging with their recovery.
It requires a full partnership. That's where cardiac rehabilitation comes in. It's a structured program of exercise and, just as importantly, intense patient education. It's about changing the risk factors that got them there in the first place: diet, smoking, high blood pressure, cholesterol, diabetes.
And just to close the loop on therapy, we're even seeing new ideas emerge, like using anti-inflammatory drugs long-term.
That's right. It's the new frontier.
Wow.
For some high-risk patients who have more events, even on all the standard drugs, we're now looking at adding low-dose colchicine to tamp down that chronic inflammation.